Okay, so I think we should get started. So welcome everybody to the September edition of the CMR Journal Club. Today we have a very interesting topic, and it's not about patients, it's not about technology, it's mostly about typically healthy people, namely athletes. And we have two papers that we will hear about today, both coming mainly from the Department of Cardiology of the University of Amsterdam. And the first one, Martin, I'd like you to share your screen. So the first one will be presented by Martin van Diepen. He is the second author on the paper called Extreme Phenotypes of the Female Athlete's Heart, a sports-specific CMR imaging study. It was published in the European Heart Journal Cardiovascular Imaging a few weeks ago. So Martin, please take it from here. And sorry just to remember, about 10 minutes, just walk through the PDF, and then we have some discussions and not too much detail on the methodology. And for the audience, whoever wants to ask a question, just post it in the chat or speak up once we're in the discussion. Okay, Martin.
Okay. First of all, thank you very much for the invitation, and I'm also glad that you invited Joel. So he's basically my partner in crime in the research. So it's very nice to do this together with him. Yeah, so I'm a research fellow at the Department of Sports Cardiology at the Amsterdam University Medical Center, and together with Dr. Van Hattem, I was able to write this paper in the last years called Extreme Phenotypes of the Female Athlete's Heart, Sport-Specific Cardiac Magnetic Resonance Imaging Study. So I will not pass the graphical abstract, but I will do that after this conclusion. So yeah, for the background, maybe you're not very much into sports cardiology, but the athlete's heart adapts to sports like prolonged exercise or repeated bouts of exercise, and that will cause that the volumes and mass will increase, and this mimics cardiomyopathy. So the main challenge in sports cardiology is to differentiate physiological adaptation from pathology. That's based on frameworks. So strength-trained athletes will show more hypertrophy versus endurance-trained athletes will show more volumetric remodeling. But those frameworks are only based on echocardiographic observations in male athletes to the utmost extent. And nowadays, of course, there's 50% female participation in Olympic athletes. So Olympic Games. So it's very important to also include more female athletes in exercise-induced cardiac remodeling studies. Well, there was some echocardiography data, but cardiac MRI more precisely quantifies the cardiac indices, including the myocardium and the right ventricle structure and function, and it adds T1 and LGE. So with that, we aim to investigate the extremes of female sports adaptation using contrast-enhanced cardiac MRI in a large cohort of elite female athletes. And by doing that, we hypothesize that there will be volumetric expansion, but to a lesser degree, myocardial hypertrophy quantified by mass and wall thickness. To accomplish this, we performed a cross-sectional analysis of female elite athletes only, who are included in elite study, the evaluation of lifetime participation in intensive top-level sports and exercise. And elite gathers standardized cardiovascular screening data, including contrast MRI of all elite athletes in the Netherlands. And we performed this in 5 centers, so it's a multi-center study. And yeah, what are the elite athletes? Those are Olympic, national, or international athletes, and we included only at 16 years of age and older. And they work out for more than 10 hours a week, and they are all competitive. We excluded athletes with cardiovascular disease, so we're truly looking into the physiological adaptation and MRI results. And we excluded para-athletes, so Paralympic athletes who likely have different adaptations to sport. Our focus was on the left ventricular remodeling index, and we calculated that by the mass divided by the end-diastolic volume. And additionally, we compared left ventricular, right ventricular volumes and function, and also the maximum wall thickness. We of course collected demographics, but next to that, we also recorded cardiopulmonary exercise test data, which is also important for athletes, of course. I wanted to highlight that as well. And of course, we performed this in cardiac MRI. Otherwise, I would not be in this meeting. We performed it on a 1.5 or 3.0 Tesla MRI scanners. And the images were quantified in Circle. We used artificial intelligence built in of Circle and manually adjusted the images of the short axis. And we derived all measurements from the short axis CNEs. In addition, we collected T1 and ECV mapping data, which will be also presented by Joel in a bit. But the paper was still under review when this was published. And extracellular volume was calculated for, using standard formula. In the analysis, we focused on the left ventricular remodeling index overall in the whole group of female athletes, but we also compared it within the sports categories according to the EC. So we compared it between female skill power athletes, endurance athletes, or mixed athletes. And we compared all the means to reference values according to Cowell-Boehm. Those are generally accepted CMR metric reference values. And in addition, we performed a backward stepwise multiple linear regression analysis on the remodeling indices. So let's go to the results. We included a total of 173 athletes, were average of 25 years old and predominantly Caucasian. So we included barely any other ethnicities. They participated in sport for 12 years on average and for 18 hours weekly on average. Here we can see that the female athletes who were included were predominantly hockey, road cycling, water polo players. They had a low resting heart rate, normal low blood pressures. And as you can appreciate here that their VO2 max in milliliters per kilogram per minute is 47, which is, if you know the reference range for females, it's pretty high, but it's not only endurance athletes, so that's also important. And they performed at a 300 watt maximum. So the overall cardiac MRI indices compared to the reference values of Cowell-Boehm are shown in this forest plot. Here we can see that the left ventricular and right ventricular volumes increase around 50% in size compared to the reference values. Also, there were reduced left and right ventricular ejection fraction. What was also interesting is that left ventricular mass and the wall thickness were not as much as increased opposed to the reference values, only around 10%. And also, when applying reference values, the extracellular volume and the native T1 did not that much change overall. So when we look into the distribution of the cardiac phenotypes, also when applying the upper limits of the reference values, and we saw that a minority of athletes, only 11% maintained the normal geometry, so a normal left ventricular end-diastolic volume and left ventricular mass, but the majority had increased volume, and only a small proportion of athletes, less than 20%, had to increase mass, and this was also only in conjugation with volumetric increase. So when we looked at the comparison between the power scale mixed and endurance athletes, we also saw differences in remodeling. So the power scale athletes had the lowest end-diastolic volume, and mixed and endurance athletes, mixed being the soccer players and endurance cyclists, had comparable end-diastolic volumes. And what was interesting was that left ventricular mass was only elevated in endurance athletes, whereas wall thickness was comparable between all groups. The same occurred to the right ventricle, where mixed and endurance athletes had the same amount of ventricular adaptation. And whereas there were increases in left ventricular metrics, there were no differences in tissue characteristics, which is quite interesting. Maybe we can discuss that in a bit. So what we saw when we went back to the reference values, there was the most normal hearts were in the power and skill group, of course, but the most remodeling was in the endurance group, and the endurance group was the only group with a larger proportion of increased left ventricular mass and volume. So here we can see the distribution of the metrics where we focused on. So with the endurance athletes in purple, showing the largest volumes and mass. And when we looked into the multivariate linear regression analysis for left ventricular EDV, LVM, and RV EDV, we saw that body surface area was strongly correlated with all metrics, and also that all metrics were inversely correlated with resting heart rate. So that the volumetric and mass metrics were higher in athletes with lower heart rate, which is also to be expected. There were some things I wanted to discuss with you. So what we found in conclusion is that the heart of elite female athletes predominantly manifests as a balanced biventricular dilatation, with only modest increase in cardiac mass and mildly reduced extracellular volume. Isolated left ventricular dilatation was most prevalent, and increases in left ventricular and diastolic volume and left ventricular mass were only seen in 18% predominantly endurance athletes. So our study emphasized that volumetric expansion is most common feature in female athletes, and that left ventricular and right ventricular volumes are very close to each other. So it's highly balanced. And by our focus on elite athletes, we look at the most pronounced physiological adaptation. So this is the most that you can expect in any athlete. And what was also what I skipped was that the LGE was not common among the athletes. So there were no athletes with pathological LGE during the screening, and the tissue characteristics were all normal. So this confirmed that the changes represent healthy adaptations rather than pathological adaptations. So Matthias, should I jump to the conclusion and have the discussion together, or?
Yeah,
I think that's better, right?
Yeah, it's probably better. Yeah.
Yeah. So to conclude, like I said, that there's a balanced increase in ventricular volumes with only limited increase in mass, and was only seen in endurance trained athletes, and that clinically relevant changes in left ventricular wall thickness and tissue characteristics are minimal absent. Also in athletes where you would expect wall thickness increase, so like strength trained athletes. So yeah, that's where our finding points were, that it's a healthy adaptation, and it's only volumetric. So looking forward to what you think about it. Thank you.
Well, thank you very much. That's certainly extremely interesting. For me, it was stunning by how much volumes, especially in systolic volume changes. That was really, I mean, going up to almost 100%. or 80%. That's huge. And it just, to me, is a nice confirmation that ejection fraction and volumes have to be always seen in context. So just saying, hey, looks like dilated cardiomyopathy, there's a low ejection fraction and a high volume, that wouldn't cut it. What was to me a bit surprising, I have to say, that the myocardial T1 was not altered, because we know from previous papers that Sven Plein's group has published that in athletes, but they had mostly male athletes, the T1 was lower, and I think we'll hear about from Joel later.
Exactly.
And to me, that is a very interesting. I was very excited about all this, because if you see just hypertrophy, you do not know, as you said, is it an adaptation or is it pathological? And just looking at morphology, you will not learn a lot. But if the extracellular volume is low and T1 is low, then you know that's mostly cardiomyocytes. And I have been in Calgary involved in some research in Olympic athletes. It was absolutely stunning to see how they respond to maximum exercise, that their hearts are able to expand so widely and still contract with a high ejection fraction under load, that immediately visually understood what defines a super athlete from us guys who just do sports, and at least from myself, and hardly ever gets to a competitive level. And that also made me understand why things like myocardial scars may limit someone in a way that he will never make it to a gold medal, even if he or she tries very hard. So there's one question from, or questions from Alexander. Do you want to unmute yourself and ask yourself, or do you want me to read that, Alexander?
Oh no, I can go ahead. Thank you so much. Congrats on the great study. I really enjoyed listening to it. And I have two questions actually. So did any of your parameters, when seeing those differences in between the types of sports, did any of those parameters directly correlate with your VO2 max, so you can potentially differentiate which is impacting the VO2 max the most? And the second question, sorry, you can go ahead with this one first. Sorry.
Okay, well, thank you for the compliments, and thank you for your great question. We also performed a multivariate linear regression, with CPET variables inside it, and they were highly correlated with the CMR outcomes, of course. So with the end-diastolic volume, with the left ventricular mass, and with the right ventricular volumes. But we use a maximum wattage for that, and not the VO2 max, because we had more data on that. So not every athlete had the CPET. So we were a bit limited by this sample on CPET data, but we saw a strong relationship, of course, between the heart size and also the mass and the max CPET variables. And only for the left ventricular mass, it only remains slightly associated with endurance type of sports. That was the only sport that added a bit of left ventricular mass on top of your max exercise capacity, which was also interesting.
Thank you so much.
So next question.
Do we still have time for a second one?
Yeah, but very short answer.
Thank you.
Okay. So just a quick question. We often get referred patients with low normal EF when they're elite athletes and dilated phenotypes. I feel your cohort has rather normal to high normal EF. Could this be a sex-specific difference that you plan to investigate that?
Thank you. That's also an excellent question. There are two tiny things I want to add. Male athletes have a slightly lower ejection fraction, but also not in the range of heart failure, of course. And colleague Guido Klaas has an excellent paper on athletes with reduced ejection fraction, and there seems to be an overlap in the athletes that have it with some genetic predispositions.
Okay, thank you very much, Martin. So in the interest of time, could just unshare your screen, and then Joel, if I could ask you to share. So now we will move to a equally distributed sex group. And the paper that you will present is called, and published also in the same journal, Native T1 mapping times are strongly influenced by elite athlete status. So thank you very much for coming and joining and presenting, Joel.
Yeah, thank you for the introduction. As said, my name is Joel Duint. I'm also a research fellow at the Amsterdam University Medical Center, and I'm very honored today to be here to present to you our recently published study on native T1 mapping times in elite athletes. And we'll come back to the central figure later on. As Martin already highlighted, the main focus of the sports cardiology department is to differentiate the exercise-induced cardiac remodeling from early onset cardiomyopathies. And T1 mapping has been proposed as a reproducible, non-invasively derived parameter to differentiate between these etiologies. And the athlete's heart had been associated with lower native T1 times, but this has only been based on a single center study with more or less 30 male endurance athletes. There were no female athletes included in this. And there have been some other conflicting papers published as well. We therefore try to aim to determine the differences in native T1 between elite athletes with extreme exercise-induced cardiac remodeling, as Martin just highlighted, and healthy non-athletic controls and volunteers. And to do so, we used a cross-sectional observational study design comparing elite athletes to healthy controls. The elite athletes were the same, were included from the same cohort as Martin just explained. This is the elite cohort, and we collect the standardized cardiovascular screenings data of elite athletes in the Netherlands that all participate at the highest national, international, or Olympic level. For this analysis, we've excluded the Paralympic athletes just because they've been demonstrated to have a different kind of cardiac remodeling, which is associated to the disability that they have. Our healthy controls comprised of two different groups. One were retrospectively collected anonymized healthy controls, and other were healthy volunteers. It's important to highlight that none of the retrospectively included individuals showed any signs of myocardial disease or had a diagnosis of hypertension and diabetes mellitus type 2. All our CMRs were performed on the same MRI machine, which was a Siemens Avantofit 1.5 Tesla MRI machine. And we performed the native T1 modified loop logger inversion recovery sequence. And 15 minutes after contrast admission, we performed a post-contrast T1 mapping sequence. I also used circle cardiovascular imaging, and we manually traced all the native and post-contrast T1 maps. And we tried to aim for very conservative tracing, and we excluded a margin of 50% from the endocardial and epicardial contours. Based on the native T1 and post T1 mapping times, we also calculated extracellular volume. Our main metric of interest was the global and mid-ventricular septal region of interest native T1 time, and our secondary outcomes were the segmented native and post-contrast T1 times according to the American Heart Association 16-segmented model. For our statistics, I think it's most important that we compare the female athletes to the female controls and the male athletes to the male controls. We put the results in a forest plot, and we also use density plots to see how the normal distribution changed. And we also included the standard cutoff values of +2 and +6 as the difference away from the mean. Afterwards, we were also very interested in seeing which parameters predict a lower T1. And to do so, we used lasso and ridge regression to find the very robust variables that to include in our model and to see which one predicted native T1 the best. If we then take a look at the population characteristics, we included 240 athletes and 80 healthy controls. Both of groups had 50% of females. There was no difference in age, height, weight, and body surface area, but as expected, we observed a lower heart rate in the athlete groups for both the females and the males. And as expected, we saw more left ventricular and right ventricular dilatation. We also observed a higher mass in the athlete group. And for the males, there was no statistical difference in the average and maximal left ventricular wall thickness. But in the female group, there was in this sample of athletes, with it's a very tiny difference, still less than a millimeter. We observed no differences in native blood pool T1, and we constructed a synthetic hematocrit because not all of our patients had undergone hematocrit clinically, but we observed no differences between those groups. If you then take a look at the first forest plot, it's the overall group of athletes compared to the healthy controls. We can see that the athletes have lower T1 values for all segments, from the basal to the apical slice. And there's a mean difference of global T1 of 22.9 milliseconds. And for the septum region of interest is minus 15.5. Then if we take a closer look at the female specific difference, we can see as well that there's a difference across all segments, but also a larger difference in mean difference. The global T1 had the female athletes had a lower global T1 of 31 milliseconds and the septum region of interest T1 of 26.4. Then for the male athletes, we can see that the differences are a bit smaller, and there's two segments that aren't different compared to the controls. But overall, the male athletes still demonstrated a lower global T1 time of minus 14.7 milliseconds and a septum region of interest T1 of 4.6. If we then continue to the density plots, we can appreciate that there's a shift to the left for the normal distribution of the native T1 in both the female and male athletes, but also that the female athletes' normal distribution shifts a bit more than that of the male athletes. And in this plot, we also included the two standard deviations and 6 standard deviations differences. And if we first take a look at the male distribution, we can see that although the normal distribution is shifted a bit to the left, the cutoff values for the 2 standard deviations and 6 standard deviations are still more or less aligned. But we see, especially if you take a look at the female athletes, that shift to the left holds for larger consequences for the 2 standard and 6 standard deviations cutoff. And then we'll go back to the segmented T1 times. What we see here are the 16 segmented representations of the T1 time in the elite athletes and in the healthy controls. And on the top side, the 2 smaller circles are the females, and on the bottom are the males. And you can appreciate that there's a difference between all groups, but it's not evenly distributed. And athletes showed the lowest native T1 in the basal and midventricular lateral, anterolateral to infralateral wall. Let me see. Yeah, we also calculated the extracellular volume, and we observed that the male athletes had a lower extracellular volume compared to the female athletes. And then if we move on to the univariate and multivariate analysis, those are presented in this table. We included age, sex, lead athlete status, heart rate, body surface area, left ventricular end diastolical volume, left ventricular max, and average left ventricular wall thickness, and native blood pool T1. And all of these measures were individually associated with native T1. We then performed lasso bootstrapping and rich regression to determine which variables are robustly included in this model. And we only included the ones that were variables that were included in the sample more than 50% of the time. And the multivariate analysis results are to the right. So we didn't observe association between age and native T1, but that can be just due to the smaller age range included in the sample, because previous studies have demonstrated that age is associated with native T1. And the only significantly associated variables were elite athlete status, heart rate, average left ventricular wall thickness, and native blood pool T1. Let me see. I I found it very remarkably that in the multivariate model that sex wasn't included in the model anymore. And I think that might be due to the inclusion of, for example, heart rate, because we know the male athletes demonstrate a slightly lower heart rate than the female athletes. And by including the other measures of left ventricular remodeling, I think sex falls out of the model. But I think still on a cellular level, I think the sex differences in hormone levels and intracellular mechanisms, including also genetic expression and epigenetic remodeling, cause differences to the myocardial tissue composition and also modulate the response to the frequent and intensive training that they do, which also leads to the sexually dimorphic phenotypes of the exercise-induced cardiac remodeling. What I also found remarkable is that elite athlete status was independently associated with native T1, regardless of left ventricular and diastolical volume and mass and wall thickness, indicating that even in the absence of these markers of cardiac remodeling, performing high intensity exercise still leads to changes on a cellular level. And I think it's very important to know to highlight that this model only explains 51.4% of the observed variance in this model. So there are definitely other factors that also play a role in determining the native T1 that we still have to take a look at. I think it's very important to know that the difference in T1 time for athletes is also persistent in females. And while there is a difference in native T1 for female and male athletes, I think the difference in female athletes is much larger. And especially with the difference in the cutoff values for the 2 standard deviation and 6 standard deviation cutoff values, I think it's very important that when we are interpreting T1 times in the female athlete population, that we should definitely use athlete-specific reference ranges. Yeah, I would like to thank you for your attention.
Thank you very much. It's also very interesting, and overall it confirms some of and extends some of the previous research, especially the lower T1 as discussed before, reflecting very small extracellular space, absence of edema, and probably a true hypertrophy in terms of an adaptation of cardiomyocytes, which then also begets a soft heart that is able to be compliant, able to adapt to large volumes. So that all makes sense. And it also, it's so important what you said is that we have to make sure that if we assess patients, if we study athletes with CMR looking for tissue, we have to use this context and not the standard values. Of course, the obvious question here was, you found that T1 was even lower in women, but in the previous study, Martin, you presented the T1 was not really different. What is the explanation for that?
Yeah, the main explanation for that was that we used the reference values, so it was not from healthy volunteers or controls on the same scanner. So there's, as you know, a lot of intermodality and scanner system variability. So the reviewer wanted to add those reference values, although it is not truly correct to do so.
Yeah. Okay. Okay, so here comes a question, or maybe it's a comment, and I would be really interested in your thoughts. We know from previous research that T1 in women generally tends to be higher than in men. So, and the question is, of course, why is that? Now, we also know that there are certain diseases that predominantly occur in women, especially in elderly women, which one of them is HFpEF and the other one is Takotsubo. Both are characterized by edema. So edema would also increase T1. And we have also some preliminary data, and we have actually just a paper on that in press now, that women respond to stress differently from men and actually is associated with higher T2, which would explain why stress-induced cardiomyopathy is more disease of women, and maybe even HFpEF, which is also predominantly women. So this here that you have, you probably had higher values in the healthy population between the groups in females, that this value is lowered significantly by an athlete status. So I think that's an interesting observation, and we probably have to learn about that. But any thoughts or speculations of that on that?
It's a very interesting finding. I'll look forward to reading this paper. I think
and of
it
course
is.
The question, sorry if I could add that, and the question of course is, did you also look at T2, because this would kind of address this to some extent?
Yeah, we don't perform T2 mapping standard in our athletes, and for the healthy controls, they're partially healthy volunteers in which we did perform the T2 just to have an extra marker to be sure they don't have any other diseases. But retrospectively collected healthy controls, they also didn't undergo T2 mapping. That's why we didn't include it in the whole paper as an analysis. And I'm not entirely sure why this difference exists. But from our study, because Martin has now presented the differences in female athletes, but we have also, of course, compared the female athletes to the male athletes, and we see different patterns of cardiac remodeling in male athletes compared to female athletes. So what Martin also demonstrated is like the female athletes very rarely demonstrate an increased left ventricular wall thickness, while the male athletes, especially the endurance athletes, more frequently demonstrate the increased left ventricular wall thickness. I think those differences are just tiny highlights of what there's a difference in remodeling and whatever is underlying this difference in remodeling next to sex hormones, because that's the obvious thing to investigate. I'm very much looking forward to seeing that. We also collect genetic material for our athletes, so we are planning on doing a genetic analysis as well to see which kind of polygenetic factors might make your heart more prone to dilate, or might make it more prone to thicken, just so we have a better understanding of this process.
Okay, so we're already way over the time. Thank you so much. To me, that was fantastic. And both of you for the presentation, Martin and Joel. And it's really good science because it answers questions and it raises new questions. And this is how good science should be. It helps us going forward, and there's a lot to learn and a lot for future research to be informed about. So Nicole can unfortunately not join us today. So she will announce the next journal club, the topic for next journal club in October as soon as possible. And until then, I wish you a wonderful time. Stay informed, stay curious, stay healthy, and all the best. And thanks again for the presentation, and until soon.
Right.
Bye.
Thank you very much.
Thank you.
Bye-bye.